Okay, so we know that people are going to keep, coming in after we start, which is okay. People have clinical duties, but I'd like to welcome everyone to December 2022's Medical Grand Rounds. We've got a great speaker today, and I'm going to introduce him in a second. Just a reminder to fill in the sign-in sheet at the back, and we are obviously in space, but nice to be back in person. Everyone keeping their social distancing. We also have people watching virtually from home, and this will be archived. There's a lot of people who couldn't make it today that will want to watch Dr. Rotstein's presentation, and it will be available on the medical education website. I'd like to thank Mitch Green, our education specialist, and Andrew Bourne for helping facilitate this, as well as Derek Ross from Aver Pharmaceuticals. So I'm going to introduce our speaker. I've got his bio here, so I'm going to read it because it's quite impressive. So we've got Dr. Coleman Rotstein. And Dr. Rotstein is a professor of medicine in the Division of Infectious Diseases at the University of Toronto and attending physician at University Health Network Toronto. He received a Bachelor of Science at the University of Toronto and earned his medical degree at the University of Calgary in 1976. Dr. Rotstein completed his specialty training in internal medicine at the University of Toronto and pursued further subspecialty training in infectious diseases and immunology at Medical University of South Carolina in Charleston from 80 to 83. Dr. Rotstein is currently the Director of Oncologic Infectious Diseases of the Immunocompromised Host Infectious Disease Services at University Health Network. He was a member of the board of Canadian Foundation of Infectious Diseases until 2021 and the past chair of the awards committee of the foundation. Dr. Rotstein is also a member of the National Advisory Committee on Immunization of the Public Health Agency of Canada from 2017 to 2021. In addition, he's been elected a fellow of the American College of Physicians and Infectious Disease Society of America. He's also a fellow of the European Confederation of Medical Mycology. He functions as a reviewer for several international journals. Dr. Rotstein's published over 200 peer-reviewed papers. His research interests have focused mainly on infections of cancer patients and other immunocompromised hosts. So a true world expert. So we're very lucky to have Dr. Rotstein here with us today, and I'd like to welcome you and thank you so much.
Thank you very much, Chris. For all those who don't know me, I'm Coleman Rotstein, as you've heard, from the Immunocompromised Hosts Infectious Diseases Service at the University Health Network. My topic for today is advances in the care of infections in neutropenic cancer patients. I have to provide for you my disclosure statement. I have financial conflicts of interest, grant and research support from a number of companies. I've been a consultant for a number of companies and also been on the Speakers Bureau for a number of companies. I'd like to tell you about my objectives today. First, I'm going to provide an overview of causes of infections in neutropenic cancer patients. Then I'm going to briefly discuss some novel antibacterial agents for these infections and why we have to use them. Then I'm going to describe the changing landscape of invasive fungal infections in neutropenic cancer patients and end up with one or two slides about COVID-19 and how COVID-19 promotes invasive fungal infections in cancer patients. Well, let's talk about infections in cancer patients. Why are we talking about this? The reality is that since 1973, the lifespan of cancer patients has really improved quite dramatically, particularly in AML. And you'll note here that with the supportive care measures that we have today, these patients have been enabled to survive longer, notwithstanding the fact that they get more chemotherapy. So despite all the chemotherapy that they've been given, they're able to survive longer. The most important defect, however, in these patients is clearly neutropenia. And as you will see here, as the neutrophil count drops, that is the absolute neutrophil count drops below 0.5 in particular, and when we go down to 0.1, there's an exponential increase in the number of infections seen in cancer patients who are neutropenic. So what are those infections? Let's first talk about bacterial infections. The most important defense that we have against bacterial infections, of course, is the neutrophil. As a result of this, if we don't have neutrophils, we're going to be infected with organisms that colonize the skin and throughout the gastrointestinal tract. If we have a problem with antibodies, and I'm going to allude to this a little later on when I talk about multiple myeloma patients, we are also predisposed to infections, both gram-positive cocci and Enterobacteriaceae. I'm really not going to spend a lot of time talking about cell-mediated immunity today, but needless to say, when there's a defect in cell-mediated immunity, we're predisposed to infections such as those caused by listeria, mycobacterial infections, and also nocardia. And that may be seen in an ALL patient or also a lymphoma patient. With regard to fungal infections, when we don't have neutrophils, we get invasive candidiasis, invasive aspergillosis, and also mucormycosis. In addition, we can get pneumocystis, which is protected by the T cell, but we also see it occasionally in profoundly neutropenic patients who have deficient T cell function for a prolonged period of time. Finally, we do see viral infections. As I just mentioned, when we have someone who's neutropenic for a prolonged period of time or pancytopenic, there's also deficient T cell problems. So we will see certain viral infections, COVID-19, we'll see influenza, we'll see adenovirus infections, RSV infections, as we're seeing right now. But in addition to that, we'll also have the herpes simplex family infections. Now, if we look at this overall, this is a schema that I'd just like to go over with you quickly, and consider a patient with AML who gets chemotherapy. They become neutropenic, as noted on the top left. They develop mucositis because of the chemotherapy that they've received. They have central venous catheters in place. As a result of that, they become infected primarily with bacteria, and that is usually within the first 5 to 7 days of profound neutropenia, and they get infected with gram-positive cocci that colonize the skin and gram-negative bacteria that colonize the GI tract. Of course, they can get herpetic infections at any time due to the stress involved with their profound neutropenia. Next, I'm just going to mention the invasive fungal infections they get. Candida comes in because we eradicate the usual bacterial flora of the GI tract, and then Candida takes over that niche. If we don't use antifungal therapy, that is antifungal prophylaxis, so we get Candida infections within the first 7 to 10 days, and then by day 10 to 14, we'll start to get into aspergillus infections and mucor infections. So with prolonged neutropenia, we tend to get aspergillus and mucor infections. Then the marrow recovers after the patient gets chemotherapy. With marrow recovery, we then give a second course of chemotherapy, that is consolidation chemotherapy, and the whole schema repeats itself. Once again, bacterial infection, once again, invasive fungal infection. However, today, it's different, somewhat different, that is. Those same parameters are still true that I just talked about. Profound neutropenia, the effect of chemotherapy, and the types of infections you get, but the bacterial infections today are somewhat different. And what I'm going to talk about next is ESBL producing Antibacterial, and I'm going to talk about multi-drug-resistant Pseudomonas aeruginosa, carbapenem-resistant Enterobacteriales, vancomycin-resistant Enterococci, and MRSA. Well, how do I know these things are now becoming more prominent pathogens? Let's take a look at a study that was done in Italy, a multi-center study between 2009 and 2012. And all they looked at in this study was bacterial bloodstream infection. The surprising thing is, yes, they had gram-positive infections, accounting for about 45%, but the gram-negatives predominated, accounting for almost 55%. Among the gram-negatives, please note at the bottom of the slide were multi-drug resistant organisms, things such as Enterobacter cloacae and also Pseudomonas aeruginosa. Let's go to the next study that looked at this phenomenon between 2002 and 2015, and they looked at 9,080 patients with profound neutropenia, and this included auto stem cell transplants, allo transplants, and patients with acute leukemia. And a number of these, 16%, developed bloodstream infection. This study was done in Germany, Austria, and Switzerland. Mortality was 2.5% within 7 days, but rose to 5.1% in 30 days. What were the key pathogens? The pathogens associated with mortality were Pseudomonas aeruginosa, Klebsiella species, Enterobacter species, Serratia species, and surprisingly, Enterococci. In fact, gram-negative bloodstream infection and candidemia were associated with ICU admission within 7 days of the bloodstream infection. Well, how about early death? Early death did occur with certain pathogens. On the left, you'll see the pathogens listed. I want you to focus in on Enterococcus. I want you to focus in on KES, that stands for Klebsiella, Enterobacter, and Serratia, and also Pseudomonas aeruginosa. It was the Enterococci, it was the Klebsiella, Enterobacter, Serratia, and Pseudomonas aeruginosa that had the highest risk of death. And you'll notice that the adjusted odds ratio was highest with Enterococci, with Klebsiella, Enterobacter, and Serratia, and also Pseudomonas aeruginosa in the fifth column to the right. How about VRE? I just told you it was associated with death. How do we know that is the case? Well, a systematic review was done and looked at VRE in cancer patients. The prevalence of VRE colonization was 20%. In particular, in hematologic malignancy, it was 24% and highest in patients with acute leukemia. It was associated with vancomycin use and hospitalization within 3 months. The key issue here, and the bottom line is, when you're colonized, you're about 24 times more likely to develop bloodstream infection. So we take particular interest in our patients colonized with VRE. And if we use empiric antibiotics in these patients, because they develop a fever, we make sure that we cover them for VRE. Now, let's just take a break from acute leukemia and let's talk about multiple myeloma. There are other patients, such as patients with multiple myeloma, patients with lymphoma who are predisposed to infection. In particular, in multiple myeloma, when you go with daratumumab as chemotherapy, you've gone through a number of lines of chemotherapy first, often. Now, please note that daratumumab is associated with an increased risk of severe infection. It is also associated with a 38% higher risk of severe pneumonia. And that is shown in the forest plot on the bottom with regard to severe infection. And you can see that the overall confidence interval is predisposed to severe infection, and it's on the right, meaning that it has the highest risk of severe infection. Now, There have been some advances, however, in treating these nastier bloodstream infections. Let's look at some of the medications, our antibacterial armamentarium that we now have. To treat ESBL-producing Antibacteriales, well, we have meropenem. And sometimes Piptazo works, but I would not advocate the use of Piptazo for an ESBL bloodstream infection in neutropenic cancer patients. For MDR, Pseudomonas aeruginosa, we have ceftolozane tazobactam. It's a newer agent, and we can use prolonged infusions with ceftolozane tazobactam. So use drugs to their pharmacokinetic advantage, and thus provide adequate levels above the MIC of the organism for a prolonged period of time and hopefully eradicate the pathogens. For carbapenem-resistant Enterobacterales, we have ceftazine avibactam. It's not available in Canada, and we really can't get it in Canada. However, we do have cefdurocol available on a compassionate basis through the federal government, special access. For VRE, we have daptomycin and linezolid. Now we have a larger armamentarium for MRSA, vancomycin, daptomycin, ceftobiprole, and in fact, ceftobiprole was recently compared to daptomycin for treating Staph aureus bacteremia, and 45% of those cases were MRSA, and lo and behold, ceftobiprole actually did slightly better than daptomycin, which was surprising. Success with ceftobiprole was 69.8% compared to 68.7% for daptomycin. And finally, a newer agent, I'm sure you haven't heard of this one, dalbavancin. It has been approved in Canada, and it's a drug that we can use once a week, 1,500 milligrams once a week to treat MRSA. Well, we've talked about the bacterial pathogens that we see in neutropenic cancer patients. Are there any quality improvement initiatives that are new advances that we have to look at? And I'm going to talk about two of these right now. The first one I'm going to talk about is the question that you have to ask yourself is, if you have a neutropenic cancer patient who is febrile and has a bacteremia, do you have to continue doing blood cultures daily, even though they remain febrile? Well, a study was done recently that was based on the recommendation by the IDSA. So the IDSA guidelines say if you have a bacterial bloodstream infection, culture the blood daily for the first 3 days. If you have persistent febrile neutropenia, but don't culture the blood after unless the clinical status changes. So a study was done at the University of Virginia that looked at a pre-intervention period of August 2019 to July 2021, where blood cultures were done for the duration of febrile neutropenia, and then they intervened and created a new paradigm shift, and they said, no, just culture the blood daily for the first 3 days, and that was done between August 1st, 2021 to January 31st, 2022. So I want you to look at the graph on the bottom. You will note that red represents a positive blood culture. And you'll see that that positive blood culture was only present really during the first 2 or 3 days. Very few blood cultures were positive after the first 3 days, even though they cultured the febrile neutropenic patients daily. The bottom line here is to show that when you have someone who's febrile, neutropenic, and has a bacteremia, you really only need to do blood cultures for the first 3 days. Thereafter, despite being febrile, it's not necessary to do the blood cultures unless, and I emphasize unless there is a change in clinical status. So the bottom line here is only do blood cultures during the first 3 days for a persistently febrile neutropenic cancer patient if you have a bloodstream infection. No point in doing it thereafter unless there is a change in clinical status. Now, the second quality improvement initiative I want to talk about is central venous access device management in gram-negative bacteremia. Some people like taking out the catheters. I'm one of those people who likes taking out catheters in someone who has a catheter-related bloodstream infection that's due to a gram-negative. However, other individuals say, maybe we don't have to do it. I'm not too sure about that. So let's look at the data. This was a study done at MD Anderson between May 1st, 2017 and May 31st, 2018. They looked at catheter-related bloodstream infection defined by a differential time to positivity of 2 hours. That is, the blood cultures from the central line turned positive 2 hours before the peripheral blood cultures did, or they had the growth of the same organism from peripheral culture and the catheter tip, or they had a step down in the colony-forming units when they did quantitative blood cultures from the central line compared to the peripheral blood culture. So those were the parameters by which they determined a patient had catheter-related bloodstream infection. However, when there was a Pseudomonas aeruginosa, Enterobacter, Stenotrophomonas multifida, those were the most common gram-negative bloodstream infections. When you have catheter-related bloodstream infection with one of those pathogens, pull out that catheter. So they pulled the catheters out within 3 days. If you remove the catheter within 2 days, they say there's a significantly increased chance of microbiologic resolution at 4 days, and there's lower mortality at 3 months. So the bottom line here, the quality improvement process is remove catheters if it's a catheter-related bloodstream infection when you have gram-negative bacteremia, and remove that catheter within 2 days. Well, let's now change gears a little bit, and we're going to talk about the changing landscape of invasive fungal infections. I'm sure you've seen these data before. I think I presented them last time I presented to your group. And this is an autopsy study from MD Anderson, and they looked at 4 different time frames. First time frame, 89 to 93. Second time frame, 1994 to 98. Third time frame, 1999 to 2003. And the fourth time frame, 2004 to 2008. Well, the most common fungal infections initially in the first time frame clearly were Aspergillus and Candida. We know that. Then there was a bit of a decrease in Candida infections. That's when fluconazole came online and people started using fluconazole all the time. But there were a lot of Aspergillus infections. Back in 2003 is when Voriconazole came online, and you can see there was a drop both in Aspergillus and Candida infections, but you will also note that the red histogram represents Mucorales, and there was then an increase in Mucorales. Well, what is our antifungal armamentarium like today? I talked about fluconazole already, available PO and IV, voriconazole, PO and IV, posaconazole, available PO and IV, and now we also have another azole, which is isavuconazole. It's available both PO and IV. We also have amphotericin B IV, of course, and liposomal ampho B IV, and then we have the 3 echinocandins that are only available in IV formulation. Well, Let's look at the present day. And this is a study that came from Stanford between 2012 and 2017 and was just published in Leukemia and Lymphoma. In this study, they used no antifungal prophylaxis whatsoever. They followed patients for 12 weeks after the onset of chemotherapy, and they had 36 out of their 240 induction patients who developed a probable or a proven invasive fungal infection. The key issue was greater propensity to develop an invasive fungal infection if you had absolute neutrophil count less than 0.5 times 10 to the 9th per liter at the onset of chemotherapy. So what were the pathogens? Well, as you might expect, just what we talked about in the MD Anderson study. They were Candida organisms. They accounted for 18 out of the total 36. And then there were 17 mold infections. Lots of Aspergillus, 12 Aspergillus infection, then a smattering of other things such as Mucor, Scedosporium, and other molds. That's expected. That's when you don't use prophylaxis. So there was no real change in the invasive fungal infection landscape with no prophylaxis. But that's not where we stand today. Today, we are often using prophylaxis in AML. I'm going to return to this issue with Voriconazole in a moment, but this is an elegant study done in Korea that looked at patients with Voriconazole prophylaxis compared to the ones that did not receive Voriconazole prophylaxis. And I want you to note in the column that says Voriconazole prophylaxis, the total number of invasive fungal infections that were proven or probable were 2.5%. That is 4 out of 162 patients, 2.5%. The mold infections were 1.9%. The invasive aspergillosis infections were 1.2%. Now, if you look at no prophylaxis, well, then there you see yeast as well as other types of infection, just as what we talked about. But that's not where we stand today. Today, we often use antifungal prophylaxis. This is a study done by Corneli and colleagues that I participated in as well. And I want you to know that this sets the standard for the percentage of patients who will develop a probable or proven invasive fungal infection when you use Voriconazole prophylaxis. So on the left, you'll see in green, Voriconazole is in green, and there were only 2% of the patients who developed an invasive fungal infection. When one used a standard azole, such as fluconazole or itraconazole, it was 8%. If you look at the aspergillosis numbers, you'll see only 1% developed aspergillosis with Voriconazole prophylaxis, very comparable to what I just told you about when I told you about that study from Korea. So this sets the standards. The standard of using Voriconazole prophylaxis to prevent invasive fungal infections. And our goals are to seek a all invasive fungal infection percentage of only about 2%. And that's our goal. Now, I want to show you a study that was done with Isavuconazole, a new agent that is somewhat similar to Voriconazole because it has activity against Aspergillus, and it probably has better activity against Aspergillus than Voriconazole, as well as activity against Mucorales. So this was a study done in AML or MDS. It was a phase 2 trial, just one arm, Isavuconazole alone. At 30 days, proven and probable fungal infections were 6%. I just told you the gold standard with Voriconazole was set at about 2%. Well, yes, this is a little bit more. Possible infections, 12%. Low individual variability with regard to levels of isavuconazole. It is water soluble and therefore very good absorption. And in addition to that, only 5% liver function elevations. Now, you'll notice that if you look at probable over here and proven invasive fungal infections, when you use isavuconazole, they were few in number, a total of 3 probable and 1 proven, accounting for the 4 invasive fungal infections. What is our gold standard now for the therapy of invasive aspergillosis? The gold standard now is set out by the IDSA in the guidelines for the treatment of invasive aspergillosis. Primary therapy has been voriconazole. An alternative is liposomal amphotericin B or isavuconazole or another lipid formulation of amphotericin B. Salvage therapy, when you've gone through the primary agents, it's usually one of the lipid formulations of amphotericin B, and one may try one of the echinocandins, but my experience has not been successful when you've gone through voriconazole or one of the highly mold-active agents. I don't think the echinocandins work very well in that scenario. Now, ESO, which is the European Council for Infections in Leukemia, their recommendations for invasive aspergillosis are twofold: voriconazole or isavuconazole. In a moment, I'm going to show you the data that provide evidence that isavuconazole is very effective against invasive aspergillosis. ESCMID and the European Confederation of Medical Mycology and the European Respiratory Society say that the treatment of invasive aspergillosis can be voriconazole or isavuconazole. And what they aim for when they use voriconazole is trough levels of 1 to 5.5 for prophylaxis or 2 to 6 for more severe infections. Now, what is the basis for isavuconazole being used for the treatment of invasive aspergillosis? I'm leading up to something, and I'm going to show you something of interest in a moment. This study by Martins compared isavuconazole to voriconazole for the primary treatment of invasive aspergillosis and other filamentous fungi. There were 258 patients per arm. Isavuconazole was given first 3 times a day for the first 2 days and then once a day thereafter. Voriconazole, as you know, twice a day on the first day and then a lower dose twice a day thereafter. A lot of different patients, including a lot of leukemia patients, AML patients, ALL patients, and other patients in this trial, and it was well balanced between the 2 arms. Well, what did they find? They found when they looked at the intention to treat analysis, and the endpoint was the 42-day all-cause mortality, there was a slightly lower mortality associated with isavuconazole, which is in purple, compared to voriconazole in green. The MITT analysis, once again, slightly lower mortality with isavuconazole compared to voriconazole, but the difference was not statistically significant. Possible invasive mold infection, really no difference between the 2 compounds as far as mortality is concerned. However, there was the difference, and this is what I'm leading up to now, with regard to hepatotoxicity. The reason I'm bringing this up is this is an issue with voriconazole that we encounter time and time again. Hepatotoxicity, elevations in the liver function test when we're trying to treat invasive aspergillosis, or other side effects related to voriconazole. There are lower issues with isavuconazole, that is, lower hepatobiliary disorders, lower eye disorders, and also lower skin manifestations of adverse effects with isavuconazole and voriconazole. So when we encounter a problem like this with voriconazole, we then go to isavuconazole, and we're secure in doing that because we know isavuconazole will work. But there are some other issues that we encounter too. We encounter issues of QTC prolongation in our patients. They're on multiple agents, or they've received chemotherapy that may affect the QTC. When we add voriconazole there, we may see prolongation of the QTC. So this is another area where we then gravitate towards isavuconazole when we run into QTC problems, because as you'll see on the bottom right of the slide, there is a shorter QTC with isavuconazole compared to fluconazole, voriconazole, and posaconazole, needless to say. Finally, as you know, with patients with acute leukemia, we're using a lot of other different drugs. So what this slide does is go into drug-drug interactions between some of the ancillary agents we use in acute leukemia and our antifungal therapy. So things such as midostaurin, things such as gilteritinib, other things such as imatinib. We run into problems with drug-drug interactions, and you'll see the schema on the left for you have to be cautious. We have to modify our regimen. That's in dark green if we use voriconazole, and certainly with posaconazole, we have to avoid it, but not so with isavuconazole. So these are other situations where we may leave an agent such as voriconazole and gravitate towards isavuconazole for the treatment of our invasive fungal infections. Now, I do want to mention to you the treatment of mucormycosis. This has been looked at with isavuconazole. 42-day assessment, that is a 42-day success rate, was looked at. And with isavuconazole, the all-cause mortality at 42 days was lower than with amphotericin B. The success, we really don't measure success in mucormycosis. Rather, we aim towards stable disease. We want to see stable disease without progression. And that was a little bit better with isavuconazole. This is a schema from ECMM, that is European Confederation of Medical Mycology, on the treatment of mucormycosis. So you'll see at the top in green, you make the diagnosis of mucormycosis. You probably should use surgical intervention as well as therapy. What they say is for initial therapy, liposomal amphotericin B is the way to go at higher doses, 5 to 10 milligrams per kilogram. However, if the patient becomes stable on liposomal amphotericin B, one can graduate to posaconazole or isavuconazole. When we run into problems with toxicity related to liposomal amphotericin B, it's isavuconazole or posaconazole that we gravitate to. I want to provide a bit of a summary now about prophylaxis for our cancer patients. When we encounter an AML patient undergoing induction or consolidation chemotherapy, we should use antibacterial prophylaxis as well as antifungal prophylaxis and antiviral prophylaxis to prevent herpes simplex infections. Similarly, with use of venetoclax and azacitidine, it's recommended that we use antibacterial prophylaxis as well as antifungal prophylaxis. With ALL patients using the Dana-Farber protocol, antibacterial, antiviral, and antifungal prophylaxis is necessary. They're all necessary. And also prophylaxis for PJP, because in ALL we have profound T cell defects, and these patients are predisposed to PJP. With MDS, you're using azacitidine chemotherapy. There, once again, it is advised, although not in green, it's in pink, it's advised to use antibacterial and antifungal prophylaxis. Really, antibacterial prophylaxis is not really necessary in Hodgkin's disease. However, prophylaxis for PJP is necessary. When we encounter a myeloma patient, I think now a lot of people are using antibacterial prophylaxis, particularly with the use of lenalidomide or bortezomib maintenance, and of course, as I mentioned, daratumumab. Prophylaxis for herpes family viruses is also necessary. And because of the use of hydrosteroids in some of the therapies we're using in myeloma, prophylaxis for PJP is also necessary. I want to now end my discussion with some comments about invasive fungal infections caused by COVID-19, or I should say associated with COVID-19. Please recognize that COVID-19 does promote invasive fungal infections. So the first study that I want to talk about is the propensity of patients with COVID-19 to develop candidemia. That has been looked at in ICU patients, and it was determined that the risk factors for candidemia associated with COVID-19 were broad-spectrum antibiotics, carbapenems in particular, use of central venous catheters, corticosteroids, and mechanical ventilation. All of those things are common predisposing factors for candidemia in the general population as well. They found that in the patients who developed candidemia, this entity occurred in 50% of the patients by 30 days. This was a study that was done in Turkey. If we look at other invasive fungal infections, and I want to focus in now on invasive pulmonary aspergillosis, or what is also known as CAPA, COVID-associated pulmonary aspergillosis. An elegant study done in Wales looked at a cohort of 135 patients in the ICU in Wales and found that 14.1% of them developed CAPA. Why did that happen? Well, clearly it was related to steroids. What steroids do is they anesthetize the alveolar macrophage in patients who, prior to this, had normal macrophage function and thus predispose them to invasive aspergillosis. The macrophage is the initial defense that we have against Aspergillus conidia. If it's been anesthetized by corticosteroids, these people are predisposed to invasive aspergillosis. John Badley and colleagues did an elegant review of all invasive fungal infections, and he looked at CAPA in particular, and also invasive mucormycosis. And the risk factors associated with kappa and also invasive mucormycosis were diabetes, steroids. That's a common theme that I just mentioned because all these studies have said that steroids were associated with invasive aspergillosis, underlying lung disease, leukopenia, and malignancy. So it is the cancer patients in particular who are predisposed to this. Now, how do we make the diagnosis of kappa? The problem in COVID-19 is there are multiple pulmonary infiltrates present in the chest. The patients are on broad spectrum antibiotics. How do you make that diagnosis of invasive aspergillosis? Well, we try to use surrogate markers at times. We'll do galactomannan, or we'll do cultures. And if aspergillus is cultured, even though the chest x-ray or CT scan doesn't necessarily mean that there's aspergillus present, that is, there's a cavitary lesion or a nodule greater than 5 centimeters or an air crescent sign, it is still kappa. So we've liberalized some of the criteria for the diagnosis of invasive aspergillosis in people with COVID because they have other mitigating features of pulmonary infiltrates, and it's not easy to make the diagnosis. So now to summarize quickly, I'd like to say that infections in cancer patients are quite prominent. We've been able to allow AML patients to survive longer. That's what I said at the outset of my talk. They have prolonged periods of neutropenia. It is these periods of neutropenia that predispose them to bacterial infection. But what we're seeing now is we're seeing more resistant bacterial infections. As a result of that, we have to adjust our antibiotic therapy with newer agents that will be directed to these nastier gram-negatives that often have resistant features present. In addition, we're seeing more invasive fungal infections. But the invasive fungal infections are evolving. We're using more prophylaxis, so we're seeing invasive aspergillosis and in particular invasive mucormycosis. Depending on the situation, we also have to adjust our antifungal therapy. I talked to you about what happens when we encounter an acute leukemia patient who has a prolonged QT interval and has invasive aspergillosis. We can't use voriconazole there. We have to adjust and then use other agents, which will be equally efficacious. If we're using other ancillary adjunctive chemotherapeutic agents, such as we do in patients with AML, we have to adjust our therapy because we may have nasty drug-drug interactions with something like voriconazole if we have invasive aspergillosis present. Once again, we have to adjust our therapy. And finally, I think you have to be aware that COVID-19 promotes invasive fungal infections in the ICU setting. This is primarily related to the use of steroids, but there are other predisposing factors such as diabetes, broad-spectrum antibiotics, and mechanical ventilation that predispose these patients to kappa, that is, COVID-associated pulmonary aspergillosis. And with that, I'd like to conclude my talk. Be glad to answer any questions you have.
Thanks very much, Dr. Rotstein. I'd like to open it up for questions, and maybe can someone field questions online if they come in? Anybody have any questions for Dr. Rotstein? I've got one to start it off, Coleman, if you don't mind.
Sure, Chris.
With
Go ahead.
The kappa infections, was the steroid use associated with the 10-day course of Dex for steroid-naive patients, or more associated with people on chronic steroids or longer durations in those studies?
No, it's associated with the use of dexamethasone. As you know, It's used 6 milligrams per day in people with COVID. So this was something we saw often in people with COVID. The problem is the diagnosis, Chris, because you have pulmonary infiltrates. You don't know which ends up, in all honesty.
Yeah, 100%. And I know in our center, it takes quite a while to get a galactomannan assay back. It's a lot of times.
Which is too bad. So you have to rely on culture. And that's, if you have it cultured, don't say it's a colonizer, treat it. That's all I can say.
No, that's good advice for sure. The other question, back to one of your first slides about the 3 days of culture. If you're picking up a bacteria on your first day of culture, are you still culturing just to see if there's other bacteria that are there, like in terms of multiple bacterial subtypes?
No, I'd like to see if it's cleared primarily. Sometimes there can be multiple pathogens present, but I don't think we really have to do it beyond 3 days. And I think that's a quality improvement thing that we're instituting here as well, because there are just too many cultures sent to the micro lab. And if there is a change in clinical status of the patient, that is, they become hypotensive, something else happens, absolutely, you have to reculture. But otherwise, I don't think it's necessary.
Got it. Any other questions for Dr. Rotstein? Dr. Diodata's got a question. See if you can hear him.
Sure, go ahead. Hi, Julia.
Duration of antifungal prophylaxis. What is the typical duration nowadays that we would use? Or does it vary according to underlying disease status?
Well, it's really related to the underlying disease status. So let's first start off with an MDS patient, because they may get azacitidine and be prolongedly neutropenic for a long period of time. They need it for a longer period of time. On the other hand, someone undergoing induction, you give it to them at the time of induction until the marrow recovers, and then you can stop it, unless, of course, there is an invasive fungal infection that you're treating. Okay? So I will tell you, Julio, that we have a number of people with chronic neutropenia with AML. So they've been on antifungal prophylaxis for a long period of time. My role is to prevent them from getting an invasive fungal infection. And their neutrophil counts really run, let's say, 0.2, 0.3 for months on end. So they're on for a prolonged period of time. It depends on the scenario.
Probably just a sort of another duration question, but it's for context. So for those febrile neutropenics who have prolonged febrile neutropenia, that you decide to start on an antifungal empirically, all cultures, investigations come back negative, they recover. What's the timeline of when you can safely stop their antifungal empiric therapy in that context? So culture negative, recovered fully, non-neutropenic.
So okay, very good. Very good question. So if they recovered and there's no clinical evidence of any infection, such as pulmonary infiltrates, etc., they've recovered their neutrophil count now, stop the antifungal prophylaxis.
Okay, we've got a question online. The person's got their hand up. If they can unmute and see if you can hear their question, or more importantly, if Dr. Rotstein can hear the question.
Did they put it in the chat?
I don't know. Is there anything in the chat for a question? If people online have a question, if you type it in the chat, it might be easier than the hand up, if that's okay.
Yeah, I think so. I'm looking.
Well, while we're waiting, I have a Fox News question for you. Of all the resistant bugs and invasive fungal infections, what keeps you up at night? What are you most worried about in the future in terms of stuff that we're going to have to really struggle dealing with?
Well, my special interest is fungal infections, so I'm always worried about those guys. But as far as bacterial infections are concerned, I worry about the Pseudomonas aeruginosa. I have a number of people in the ICU who've got multi-drug resistant Pseudomonas. I find those the hardest to treat, really.
Question come up in the chat at all? Oh, it might be actually Dr. Kosovani. Let's see if he. Amir's got his
Amir,
question there.
yeah. He looks like he's typing, but I don't see anything coming across.
Must be a long question.
Uh-oh. Okay.
No, I can talk now. Yeah.
Yeah, okay, great. So Amir's question is, do I use serum galactomannan in diagnosis and monitoring therapy? Simple answer, absolutely, yes. So we combine serum galactomannan often with BAL galactomannan because we may scope the patient. So we follow serum galactomannan after we make the initial diagnosis to make sure it's coming down. If I don't see that it's coming down, and I usually do it once a week on therapy, if I don't see it's coming down, I know I've got a problem. So I have to adjust my therapy.
Thanks, Dr. Follow-up question, I can talk now. So
Great.
if BAL is negative and the serum galactomannan is positive, so what's the sensitivity and the specificity of that only positive serum galactomannan?
Okay. So if you're dealing with a neutropenic patient, or if you're dealing, let's say, with a patient in the ICU, those are two different entities. So with a neutropenic patient, I think BL galactomannan is much more sensitive. They're probably got the organism in their respiratory tree. I would treat them. Okay, absolutely. Now, let's deal with the ICU patient. So it is much more so I'll say it's much more sensitive. Now, with the ICU patient, that's a different situation. If I have a BL galactomannan that is positive in someone on broad spectrum antibiotics, let's say, and not on high-dose corticosteroids for a prolonged period of time, I probably would punt on treatment. I just follow them. Usually that BL galactomannan may be related to simply colonization. On the other hand, if there are pulmonary infiltrates present and someone is on steroids, I will then treat them. So I painted some scenarios here. Chris, you may disagree, but I'd be glad to hear what you have to say.
No, I think that's very reasonable. Any other questions for Dr. Rotstein? Julio's got another question here.
So
Sure.
on this issue of serological markers, is there any role that you would use, say, procalcitonins or C-reactive proteins in helping guide longer-term management in these patients?
I really can't comment about long-term management. I'd say initially, yes, I would agree. There's a role for C-reactive protein and procalcitonin initially, and some people have looked at that. Okay, I can't say that would be a primary role for those things because I'd like to rely on other things with regard to fungal infection. I'd believe in the procalcitonin and C-reactive protein more for bacterial infection. Long-term follow-up, I just don't know because I haven't really looked at that in invasive fungal infections.
Okay, last question. Any last question for Dr. Rotstein before we let him go? Okay, thank you so much for coming. That was a wonderful talk, and definitely will make my own practice be looking harder for some of those fungal infections. And I appreciate all your time and your expertise. And one final round of applause, Dr. Rotstein.
Thanks. Thanks a lot.
Thanks so much.
Nice to see old faces.